Hello everyone. I'm starting. I started the recording. Hello everyone. Thank you for joining us today to our Poison Hour webinar. This is presented by the Tox Interest Group via ESAM, and this session is accredited 1 hour CME DOH, and we as in the beginning, we advise you to chat. Chat is open. You can ask your questions and answer any questions that we will give you. Otherwise, let me introduce our panelists. Sorry, this is maybe a minor issue here. Give me 1 second. Apologize everyone, we seem to be having like a slight audio delay here, the slight audio issue. Our panelist, our presenter will join us shortly in a few seconds. First of all, I wanted to thank you so much for joining us today. This session will be within for almost 1 hour. It's about managing paracetamol poisoning, current evidence and best practice. I'm Dr. Samia Ghennai. I'm clinical toxicologist. I'm delighted to be moderating this session today. Paracetamol remains the most analgesic worldwide used, and consequently it's one of the most common overdoses we encounter in our clinical practice. While the Matthew nomogram has served us well for decades, the landscape is shifting and we are seeing some discussion around overdoses, the NAC regimen, and complex staggered ingestions that challenge our standard protocols. Before we dive in, we are keeping the microphones muted. You can I'm encouraging you for active discussion with Q&A, and we will try to answer all your questions by the end of this webinar. Now it's my pleasure to introduce our speaker, Dr. Lara Suleiman, who is our consultant and medical toxicologist, who will bring for us many insights, and she's a teacher. Actually, she's a postgraduate in medical toxicology from Cardiff University, and she's a core faculty and clinical instructor in Mohammed bin Rashid University and Dubai Medical University as well. She's also in charge of the toxicology rotation of the emergency medicine residency program. Thank you so much, Dr. Lara. Thank you for being here, and the floor is yours.
Assalamu alaikum. Thank you, Dr. Sami, for the introduction. And thank you all for having some time in your busy schedule to attend the lecture. So I just start sharing my screen. So as all of us, we know that paracetamol is one of the most common used analgesic worldwide. 50% of the all acute liver failure cases in the USA are attributed to paracetamol overdose. Half of these are intentional, like 50% intentional, 50% are intentional. If anyone saw the paracetamol availability in the US, let's say supermarket or pharmacies, you can see they are in large bottles where you have like 100 tablets in a one can or canister that's easy to open and take. And such things increase the incidence of overdose. And now many countries are shifting to the tablets that you have to open the strip to make it more difficult and more exhausting for the one who is trying to overdose on these medications. and in addition to child safety packages, and it showed remarkable reduction in the overdose over the years. Of the unintentional, 63% of the cases, they occur in patients who are taking paracetamol and opioid combinations, which we are recently seeing a lot of combination formulas, Panadol night, Panadol condo flu, Panadol sinus, Panadol migraine, and all of them has different combination. So it's very important for us to know which type of paracetamol the patient has taken. And mortality mainly is related to liver failure and can reach up to 30%. So basically the pharmacology, it's an analgesic and antipyretic. It has a weak peripheral anti-inflammatory and antiplatelet properties. At the level of 10 mic per ml, it has its antipyretic activity, the analgesic activity, and at 4 to 18 mic, it will have the antipyretic activity. It peaks in 30 minutes, and some extended formulations can take up to 1 to 2 hours, and the liquid formulations is around 45 minutes. And almost all forms are completely absorbed within 4 hours, and hence becomes the 4 hours level important. It can be delayed, the peak time can be delayed with co-ingestion of opioids or anticholinergic or antimuscarinic, or the patients who have any conditions that can cause delayed gastric emptying. Availability is 60 to 98%. And it has a small volume of distribution, make it as a dialyzable drug. So what's the metabolism in paracetamol? So in normal situations, the paracetamol is metabolized in the liver, where 95% of the paracetamol is metabolized to a non-toxic compound by glucothyroidization, while 5% only will be metabolized by the cytochrome P450 to the toxic compound NAPU. And again, the glutathione will combine to the NAPU to make it non-toxic and excreted to the urine, because NAPU, the product NAPU, is hepatotoxic. What happens in the paracetamol overdose, when the patient will ingest an excess amount of paracetamol that's beyond the capacity of the liver and the glutathione to convert it to the non-toxic compound, then here we'll have the hepatotoxicity related to the paracetamol overdose. And hence the treatment protocol and the pathways and the antidote all are managed on repleting the glutathione or blocking the production of NAPU. And that's why patients with a chronic liver failure or liver depleted patients usually are on a higher risk of paracetamol toxicity. And now the clinical presentation. So the first stage, it's divided into 4 stages, but the stages can overlap. It's not like the patient will go typically from stage 1 to stage 2 to stage 3 to stage 4. They can come from 1 immediately to 4. They can have mixed symptoms. Initial symptoms usually are silent or a very mild abdominal discomfort or mild GI upset. So in stage 1, and even like if you see in the hours, they tell you 0 to 24, 24 to 72, 72 to 96. These are just rough approximations of the timing. So in stage 1, there is still no evidence of hepatotoxicity, so it's mainly symptomatic. So they'll have malaise, nausea, vomiting, abdominal pain, mild signs and symptoms, and they will have most of the time normal liver functions. In stage 2, you will start to have the evidence of hepatotoxicity. You will start to have the right upper quadrant abdominal pain. You will have the rising of the liver functions. You will start to have the coagulopathy present. And in stage 3, they will reach the hepatic failure and the encephalopathy, where the patient will have jaundice, vomiting, severe GI symptoms, severe coagulopathy. They go into encephalopathy, metabolic acidosis, sometimes even as severe as pancreatitis and acute renal failure or multi-organ failure, especially in massive overdoses. In stage 4, the patient either will have resolution of their hepatotoxicity, or they will end with a liver transplant, or they will go into death. Now is how to approach those patients. So always we go with the ABCs, of course. You'll have to look at the airway, breathing, circulation, stabilize the patient. And then we have our risk assessment as in the toxicology part. Basically, the approach of paracetamol overdose, it's mainly time-based. So time since ingestion is the way we will approach those patients and risk stratify them. So take the history and physical examination. Some patients are reliable historians. Some patients, they don't give you a proper history. You need to depend on the collateral history, asking the EMS, the family members, how many tablets are available, how many missing tablets. All these things are important in the history. Then you go to the ABCs and you will go to the decontamination. Now, the decontamination here, it depends again on the time, patient status, and amount ingested. So if the patient ingested an immediate release of paracetamol, which is the normal Panadol, you can give it up to within 2 hours in those patients. But if they had a huge or a massive ingestion, which is more than 30 grams, you can extend the time of activated charcoal to be given up to 4 hours post-ingestion. For the extended release, which is now we are changing because we noticed that many preparations are extended release, we give the paracetamol we can give it within 4 hours post-ingestion. The patients who are ingested more than 30 grams or more than 500 milligram per kg, which is the massive overdose, they might benefit of multi-doses of charcoal up to 24 hours. Some studies, they supported giving multiple doses of charcoal up to 24 hours because there is a possibilities of bed formation. So the idea of the bed formation, because they ingested a massive amount or large amount of tablets at once. And this will make it difficult for the stomach to digest this amount, and the tablets will be partially digested and they will clutter together, making it like a ball and will have a continuous absorption, chronic absorption. So in these cases, the 4 hours or the single dose activated charcoal will not give benefit to the patient. So if there is no contraindication, you can give the patient the charcoal for a period of 24 hours. In kids, it will be 1 gram per kg, a maximum of 50 grams. Now is the time-based approach. So we will see how we will manage the patients based on the time ingested. So if they come in less than 4 hours of the ingestion time, you will give the GI decontamination if there is no contraindication. Gastric lavage is still, it's mentioned, but it's out or it's not doable usually. So maybe you will go with a whole bowel irrigation in such cases with high morbidity co-ingestions or or large amount of massive ingestion. Then you will decide about the paracetamol level. Do not send the paracetamol level before 4 hours because it will be inaccurate. It will give you a false result. You send the 4 hours level of paracetamol. Here you need to know what will be the turnover of your lab. If you are able to get your paracetamol level within 8 hours of ingestion, then you can wait for your 4 hours level. If the turnover of your lab or the blood sample will be sent to another lab and you will get the level beyond the 8 hours post-ingestion, in these conditions and the patient took a toxic ingestion, you will start the patient on the NAC. You will wait for the results. If it's below treatment line, you will discontinue your NAC. So the 4 hour level is your aim to decide on the NAC to start or not. If the patient is between 4 hours to 24 hours, okay, so خلاص, they came beyond the 4 hours, you will send the levels. Again, if your level will be available within 4 hours of 8 hours of ingestion, you can wait. If it's not going to be available within the 8 hours of ingestion, then you have to start the NAC until you get the level. For example, patient came to you within 6 hours of ingestion. And you know that the lab will collect the blood and you'll get your paracetamol level within 1 hour. So you are still in the 8 hour window. So you can wait. If the patient, if the lab came and tell you, no, I will take 3 hours, then the results will come after the 8 hours of ingestion. And in this condition, you have to start the NAC, wait for the level, and then decide. Now for the patients with, let's be honest, most of the patients, they are either unknown time, they are not sure, or they refuse to tell you. So here, or they come beyond the 24 hours. So in those patients, we will go with different approach. If there is unknown ingestion time, no contraindication for activated charcoal, give the activated charcoal. You can give also, start the first dose of NAC and then send the lab. Here we will not wait for the 4 hours after their arrival. We don't know the time, or it's beyond the 24 hours. You will give the paracetamol level, you will give and you'll send the liver functions and the coagulation. If the level is more than 10, or you have an elevated transaminases, which is AST and ALT, then you will continue the NAC. If you have a pH below 7.3, PT more than 100, or creatinine more than 3.3, or you have an altered mental status, this is an evidence of hepatic encephalopathy. This is evidence of liver failure. You have to consult a liver transplant center and continue your NAC. If the paracetamol level is below 10, both liver functions are normal, then you will stop the NAC. So in order to discontinue the NAC in these conditions, you have to have a paracetamol level below 10 and normal liver functions, and no evidence, of course, of liver failure. If it's a chronic ingestion, which is in the patient who they ingested it over 1 week, over 48 hours, or beyond the 24 hours, those patients, you will initiate the NAC. In any patient with ongoing or evidence of ongoing hepatotoxicity, they have a high LFTs or a paracetamol level beyond 20 mic per kg. If the patient will have normal liver functions and the level of paracetamol is below 20, then you can discontinue the NAC, or it's not required at the first place. So the difference between the one who is unknown time of ingestion and or level beyond 24 hours is the level of the NAC, the level of the paracetamol. In the beyond 24 hours or unknown time, it's 10. So we have lesser threshold. For the chronic ingestions who are like, I'm in a chronic pain, I'm taking it on a chronic ingestions, a chronic amount, they are ingesting more than 10 grams per day, they are in for let's say for a week, or more than 150 milligram per kg per day for a period of week, they are in the chronic ingestion. Those we will have a level of 20 mics per ml, and always pay attention to the unit in your lab. Then we will have the massive ingestion. The massive ingestions means ingestion of more than 30 grams of paracetamol or more than 500 milligrams per kg. Those patients can present immediately with signs of liver failure and multi-organ failure. They might have acidemia, coma, hemodynamical changes, and they will be sick-looking, hypotensive. And those patients, you need to take care in the resuscitation area. You have to start the supportive care of IV fluids, pressors. If they need to be intubated, you will intubate them. And in those patients, you will consult the poison center or the nearby or the available toxicologist even before your 4 hours. And even those patients, you start them on the NAC. If you know the time of ingestion, you will send the levels based on the time of ingestion. If you don't know the time of ingestion, you will start the NAC, you will send the levels, and you decide. And in such cases, you might consider increasing your NAC dose or double the dose even for those patients. And dialysis. We have certain guidelines for dialysis, and we will go through it. And if you decide to dialyze a patient who is in paracetamol overdose, you need to remember to double the dose of their NAC because the NAC is dialyzable also. So this is like another simplified approach with the same points and discussions that we mentioned previously. Now, I had the level. I had my 4 hours level, or I had my 5 hours level, or I had my 8 hours level. What I will do with this level? How I will know that at this level I need to treat, or at this level I don't need to? We will plot it to the Romac-Maffei nomogram. Romac-Maffei nomogram has been established since long time, after many years, with a huge number of patients. They were studied to decide the best level to use. And you can see here two lines. You have the dotted line and the straight line. And anything below the dotted line is high toxicity, a possibility of toxicity, and a low possibility of toxicity. Anything above the line, it indicates that there is a possibility of toxicity. If you can see here, it's up to 26 hours, but you'll see some of the nomograms, it's only up to 24 hours. It's only indicated for single acute ingestion within 24 hours prior to presentation. So anything beyond the 24 hours, we do not apply the nomogram on. It's not useful for chronic ingestion. It's not useful for time unknown. It's not validated also for beyond the 24 hours. If you see the dotted line, which is if you look at your 4 hours level, your dotted line will be on the 150 mic per ml. So your cut off from the 4 hours level is the 150. Anything above the dotted line is indicated for treatment. Anything below it, no indication. They kept this dotted line here because the original line was the 200, this one. But they decided to lower it to have more of a safety margin, especially on the higher risk patients of liver toxicity, like a chronic alcoholic and patients who are using enzyme-inducing drugs. Because if you remember, when we are talking about the pharmacokinetics, the 5% that is unconjugated from the paracetamol is metabolized by the cytochrome P450 into the NAC. So if you have a huge amount of unconjugated paracetamol and you have an enzyme-inducing drug taken by the patient, you will expect that those patients are at a higher risk of hepatotoxicity. So in those patients, you need to use the dotted line. Actually, most of the protocols will follow this line, will not go to the 200. We have more of a safety margin because paracetamol toxicity and the liver failure in paracetamol is almost 100% reversible if the NAC was started within 8 hours of post-ingestion. Co-ingestions of drugs that reduce the GI motility should prompt you to repeat the acetaminophen levels at 8 hours, like opiates, anticholinergic, patients with conditions or drugs that may cause delayed gastric emptying, that like now the weight loss drug, like the semaglutide. Those patients, we will have a small change in the management. You will do the 4 hours level. If it's normal, you need to repeat it at 8 hours because those patients are at higher risk of delayed presentation or delayed rise in the levels or delayed absorption. So we'll do the 8 hours level. Or if you took the level at 6 hours or 8 hours and it's normal, you need to repeat it 4 hours after this level. So we have to have 2 levels for those patients, 4 hours apart. The limitation of the nomogram. So it has not been validated for unknown time of ingestion. And you need to always check your units, if it's milligram per liter or microgram, micromole per liter or microgram per ml. You need to know these in the levels of your lab. and ingestion beyond 15 to 24 hours and modified release paracetamol preparations are not yet validated. However, if the patient comes to us still within 24 hours, we still use the nomogram for them to decide on the treatment. Okay. Special cases. We have special cases like pregnant, pediatric, different conditions, and these things. So, pregnancy. So, for pregnant women, we always have this question: shall we give the NAC? Shall not give the NAC? Pregnant women, they have some limit of faster metabolism compared to normal population. So the paracetamol here, we know it crossed the blood-brain barrier, the placenta barrier, okay? But the effect on the babies is still not yet well established, not yet well studied. So the recommendation is to use the same nomogram as the non-pregnant patient and to start them the NAC as the normal dose of a non-pregnant patient. So you'll use nomogram, you will give the NAC, the normal thing as the non-pregnant patient. There is no reported cases of fetal or maternal toxicity in women with paracetamol concentrations below the 150 line. There is no reported cases of fetal or maternal toxicity in patients who received NAC as an antidote. For the abortion, only some cases they had elective abortion, not spontaneous. And the more time or the more delay in giving the NAC in such patients was associated with higher rate of spontaneous abortion. So in such patients, give the NAC, normal protocol, normal guidelines, no changes. The ingestion of extended release, which is most of the preparations now are either extended release or in combination with drugs that will make it delayed ingestion. One of the extended release we know is the Panadol joint. It's an extended release, and the dose is actually around 640 milligram per tablet, not 500 milligrams. So you need to pay attention to the type of preparation ingested. So those patients, you have to do the 8 hours beyond, you take the 4 hours level and the 8 hours level, or you need to take 2 levels 4 hours apart. This is the thing, and you need to know that you can give them the activated charcoal 4 hours or beyond. If you have the samples drawn 4 hours to 24 hours ingestion above the treatment line, you will treat. If it's below the treatment line, but above the 10 mic per ml, you will repeat the levels at 4 to 6. So those patients, you always need to obtain a second level on those patients. Do not discharge patients who had ingested sustained release preparations without having 2 levels of paracetamol plotted below the treatment line. In such cases, 4 to 6 hours apart between each 2 levels. The co-ingestion of anticholinergic and opioid agonist medications. Why were there special consideration of such patients? Because those will cause slowing of the gastric emptying and will increase the chance of delayed absorption or delayed presentations. And again, those patients, you will be the same management, except that again, the first concentration measured at 4 to 24 hours. So the first sample after ingestion is 10 mic or less, or the amount, or the level is 10 mic or less. No need to give, no need to repeat the levels. If any of these is above or high, then you have to start the NAC. Okay, but if you take the level, which is of the NAC, between 4 to 24 hours, and it's more than 10 mic, but it's below the treatment line on your nomogram, you have to repeat your levels 4 to 6 hours after the first level. So in those patients, we have two criteria. Either the level below will be, you need to have a level below 10 mics and a negative treatment line or a negative plot on the nomogram to say that I can safely discharge this patient. If you have a detectable level of paracetamol, more of 10 mic on the lab, even with a negative treatment line, you have to repeat your blood levels of paracetamol, and then you can decide. Okay. In patients who are above the 100 kg, everyone knows that the N-acetylcysteine, the NAC, it's per kg. The doses are per kg. What if the patient is above 100? Such patient, you have to cap it to 100. So you will not give more than per 100 kg. So the 150 milligram per kg, it will be up to 100 only. The 100 milligram per kg in the third bag will be only up to 100. Do not go beyond the 100, even if the patient weight is beyond 100 milligram per, below, above 100 kilos. In patients who are younger than 6 years, you need to, first of all, speak to their primary clinician or clinical toxicologist if they received a single dose of IV paracetamol more than 90 milligram per kg body weight, or more than 150 milligram per kg body weight for 24 hours. This is specific considerations on pediatrics and the IV overdose. And sometimes of the patients who are below 41 kilos, you might need to adjust your NAC administration, and especially in the fluids, the fluid might need to be a little bit reduced to avoid the hyponatremia, because the amount of fluid given with the N-acetylcysteine is huge. Okay. A special considerations is for the IV paracetamol overdose, because sometimes patients can be overdosed by mistake in the hospital with the IV paracetamol. So we depend on diagnosing those patients mainly on the dose administered, because in the hospital settings, in the IV settings, we know how much they took. We don't care about the time. And the Rumac Matthews here is not validated and not recommended. The decision mainly is how much you give the patient. So if the patient were exposed to a single dose of more than 150 milligram per kg, you have to give them the NAC. And kids, we said that more than 90 per kg or more than 150 milligram per kg over the 24 hours. In adults or anyone beyond above 6 years, a single dose of 150 milligram per kg is enough to start the patient on NAC. Below 6 years, either 150 milligram per kg over 24 hours or a single dose of more than 90 milligram per kg. And again, in the IV formulation, if the patient is more than 110 kg, you will again do your calculation based on the maximum weight of 110 per kg. You will not say, okay, he's 150, so I will measure 150 milligram per kg for the 150%. No, it's 110 only. Now for the NAC administration. Okay, so there an IV protocol, there an oral protocol. The oral protocol is, it goes over 72 hours. Some, they prefer it because you can discharge the patient with a follow-up. Some, they are not in favor with it because of the taste of the NAC. So in the oral NAC, it's the same as an IV. The oral NAC that's given to the patient, it's the same as the IV preparation, but they will drink it. The smell and taste is bad. Usually, they have more nausea and vomiting in such cases. Okay, but in some areas, they might favor it in order to discharge the patients home with a close follow-up to reduce the load in the hospitals. But now the majority and FDA has approved the IV preparation. It's more easier and more controlled. In the IV preparation, you will give, there are different protocols. Now I will just speak about the 3-bag protocol, which is in most of the places used. It's 150 milligrams, so you have 3 doses. The first dose is the loading dose, 150 milligram per kg in 100 ml of D5 water over 1 hour. The second will be 50 milligram per kg in 250 ml D5 water over 4 hours. And the third is 100 milligram per kg in 500 ml in D5 water over 16 hours. And you have to always make sure there is no interpretations in the bag. So you start the first bag and ask the staff to prepare the second bag. So once the first bag is finished, immediately you will connect the second bag. Immediately you will connect the third bag. Because any gap, let's say within 1 hour gap, you need to restart your protocol again. Okay. There is another time, I believe that we had many times noticed that even after completing the 21-hour protocol, the patient may still have deranged liver enzymes, or they are still having rising paracetamol levels, or even sometimes they are having doubling or worsening of liver enzymes. And here we start to have what we call the extended protocol, which is beyond the 21 hours. This most of the time occurs in late presentation patients, or in patients have elevated, very high levels of paracetamol after elevated paracetamol concentrations after completing the treatment, or you have a biochemical evidence of acute liver injury. And then for those patients, you will repeat the third bag, which is the 100 milligram per kg over 16 hours infusion. When you will stop? If your ALT or AST is decreased by 20% from the highest level, you have an INR of below 2, patient is clinically well, and especially in modified release preparations, if the concentration is greater than the double of the nomogram or below the 10 milligram per liter. Okay. For patients who develop hepatic failure, we have to continue the IV NAC until either the PT or INR is below twice the normal level and encephalopathy has resolved if it's there, or when they are fit for the liver transplant. And even if they come beyond the 8 hours, beyond the 24 hours, give them the NAC. The NAC has an antioxidant properties. Already gastroenterologists are using it in patients with hepatic failure. So give them the NAC, do not discontinue it until they are improving. For patients without hepatic failure, but they have the elevated AST, you will continue it until the hepatic abnormalities will improve. The AST is decreasing and it's below 1000, or your AST-ALT ratio is below 4, because below 0.4. Because many patients, they will have ASTs and ALTs in 1,000, 3,000, 4,000, despite that the initial ALT-AST were in hundreds or 500, let's say. They might have delayed presentation, and on those patients, we will go with the extended protocol. Most of the time, we depend on the AST because it will be the first one to decrease earlier than the ALT. So that's why we say if the AST is decreasing below 1000. Other therapeutic modalities. Hemodialysis, it's a mitochondrial toxin in massive overdose, especially if you have very high levels. And dialysis is indicated in those patients. It's the paracetamol is dialyzable and the NAC is dialyzable. So remember to double your NAC dose during dialysis. This is the extra criteria for dialysis in paracetamol overdose. It's if you have more than 1000 milligram per liter in the liver, or 6620 micromole per liter, and NAC is not given. If the patient presents with altered mental status, metabolic acidosis, elevated lactate, and paracetamol level more than 700 milligram per liter, and NAC is not given. If the patient is present with an altered mental status, metabolic acidosis, elevated lactate, and paracetamol level more than 100 milligram per liter, even if the NAC is given. So the level is enough, and if it's above 1000, okay, or if uh, if they have altered mental status, regardless of availability of NAC or no, and if you give the NAC and the level was 900 milligram, you need to consider dialysis on this patient. It's not recommended if the dose of ingestion is mild, it's not severe, if the patient is not having signs of metabolic acidosis or high lactate or multi-organ failure, and the NAC is available and administered to those patients. Any patient who has no indication for NAC in general, so below treatment line, small ingestions, dialysis is not indicated for this patient. Usually, intermittent hemodialysis is preferred, but also CRRT is available. It can be used, or exchange transfusion. In some cases, they have, especially in neonate, has been used. You will start with the same idea of patient will develop clinical improvement, clinical and laboratory improvement. Other protocols. So we said that the oral is usually 72 hours and the IV is the 21 hours. We have many other protocols. We have the SNAP, which is 12 hours protocol. Some they have the 20 hours protocol, but it's the 2 bags rather than 3 bags. So they were looking into many of them. The most, let's say, studied one, or the one that many are shifting, and I was checking even the Poison Center here in the DOH guidelines are more into the SNAP protocol, which is the 12 hours regimen. It was found to have fewer side effects than the standard 21-hour protocol. It has a lesser rate of anaphylactoid reactions, and it has a shorter stay in the hospital and more tolerable for the patients, which make it more favorable than compared to 21 hours protocol. So the SNAP regimen is 100 milligram per kg over 2 hours, and then 200 milligram per kg over 10 hours. So a total of 10 hours, total of 12 hours. The total amount taken is still 300 milligram per kg. So they are not taking lesser NAC than the 21-hour protocol. Sorry. They studied, one study, they took data collected in 3,340 patients across hospitals before and after the changes, and they found that there is no significant decrease in the liver injury rates between the 21 hours protocol compared to the SNAP regimen. Adverse drug reactions has been significantly lower in the SNAP. They had 2%. Compared to the 21 hours protocol, they had 11% adverse reaction. So it's effective as a standard treatment preventing injury while reducing adverse reactions. There was no patients who got a readmission with delayed presentation after the 12 hours protocol. No fatalities from liver failure within 30 days post discharge in the SNAP in the patient who went to receive the 12-hour protocol. The limitation, of course, it's an observational study, and it might have some co-founding factor or some bias, because everyone prefers a shorter protocol, because no one wants their patients to stay 21 hours in their hospital with the whole issues of bed management and borders of the patient. We need larger studies. We need more different subgroups to decide the treatment efficacy. And we need to have more inclusive patients, like we need to study it in patients with pre-existing liver disease. It wasn't specified in the study. Patients with patients who have co-ingestion of anticholinergic, patients who had been using GLP inhibitors. All these patients need to be included in further studies to decide if it's really effective to give it only within 12 hours or we have to extend it. But so far, they concluded that the SNAP regimen offer a safer, equally effective alternative to the traditional protocol. Okay. So I believe for the sake of the time, we have other modalities. Fomepizole has been going now strong in paracetamol overdose. The idea is we know that we use it for alcohol, toxic alcohol management, but they found that it inhibits the cytochrome P450 enzyme. And this is the enzyme responsible in converting the free unbound paracetamol in the body to the toxic amount naphtha. So by inhibiting the cytochrome P450 pathway, you're inhibiting the metabolism of the naphtha. Still, it's not a standard of care. Some guidelines, I believe, even in the DOH, it's considered to be used in certain cases, but it's still not everywhere. The transplant criteria, we have the King's College criteria. Any patient who have pH below 7.3, lactate more than 3, at 12 hours after full fluid resuscitation, creatinine more than 3, INR more than 6.5, or grade 3 or 4 hepatic encephalopathy, you need to contact the gastroenterologist team and put them as a transplant potential. This is the SNAP protocol from the NHS. They have very detailed, they had a full detailed approach. These are some studies that they looked into comparing the paracetamol between the two different protocols. Okay, and again, they saw that less side effects with the SNAP, less side effects in the SNAP protocol compared to the other, the 21 hours 20 hours protocol, as well as those patients has had lesser hospital stay, shorter hospital stay, which is even better for those patients. Again, there is another study that compared the 3-bag methods versus the 2-bag methods. And again, they reached that the 2-bag method regimen is safe and effective methods in managing acetaminophen toxicity. We have a protocol in our Rashid Hospital. We use the 21-hour protocol. We use the 3-bag so far, especially that we've noticed that we have many patients who require recently we had many of the patients require even extended NAC beyond the 21 hours protocol. We had patients who stayed on NAC for 3-4 days or even 1 week due to delayed toxicity, which required to be assessed and studied, as why we recently noticed many patients they require extended protocol. Is it related to their underlying liver disease that has been undiagnosed? Is it related that they are already a fast or slow metabolizer congenitally, or it's related to the preparations that's available in the market? So I will just leave the protocol for here, and we'll just jump to the conclusion for the sake of time. So survival from paracetamol is generally considered 100% in cases receiving the NAC within 8 hours of exposure. The threshold for potential paracetamol-induced hepatic toxicity in adults is more than 10 grams or more than 150 to 200 milligram per kg, whichever is less within 24 hours. That's why we prefer to always calculate the dose per kg rather than the rough total amount. There is no standard definition of massive paracetamol ingestion, but those with initial paracetamol concentration greater than double the 150 milligram at 4 hours mammogram or 500 milligram per kg are at higher risk of acute liver injury and require higher doses of acetylcysteine. Screening and testing of paracetamol in the first 24 hours is necessary as patients are asymptomatic with even toxic doses. Beyond 24 hours, symptoms should be evident: nausea, vomiting, abdominal pain, or encephalopathy. And equally, do not discharge a symptomatic patient possibly wrong dosing calculation, or the patient took the drug or did not give you. So that's why sometimes if the patient is symptomatic, we can start them the NAC and repeat the level again. Thank you. And these are my references if anyone is having any question.
Thank you so much, Dr. Lara, for this excellent and comprehensive overview of paracetamol poisoning management. It really highlights how our management is evolving beyond just treat numbers. We had a question, and I answered it actually for to see because we are running out of time. I answered, but if you have for our dear attendees, if you have any further questions, feel free to write it down on Q&A or in chat section. For now, the only question we have right now is about the 2-hour level. 2-hour level is recommended for previously healthy children less than 6 year old with liquid paracetamol toxic ingestion for the syrup. But the point is 2-hour level is only to if it's less than 150 mg per liter, you can discharge the patient safely, and hepatotoxicity will be ruled out, and no need for further observation or levels. However, if it's more than 150 milligram per liter, you will not give NAC, but you will need to conduct the 4-hour level to decide if the treatment is needed or no, using the nomogram, which is like at 4 hours is 150 mg per liter. We approached the end of our, we didn't receive now any other question. We are approaching the end of the hour. So if this has been a fascinating session. Thank you so much, Dr. Lara. And clearly, paracetamol management is not as simple as it sometimes seems. If I could summarize today's session, I can maybe tell you about the early recognition, the appropriate risk stratification of massive ingestions, and meticulous supportive care remain the cornerstone of preventing the hepatotoxicity. Maybe I can remind you regarding the psychological, clearance. After the medical clearance, most of the cases that we are receiving are impulsive acts of self-harm. We should consider psychiatric assessment before discharge, and also we should remember if to not rely only on the ALT in some hospitals, because the ALT mainly very early presentation, the ALT will be normal even in fatal overdoses. So the normal ALT should not rule out the toxicity, and we should trust the nomogram, the timing, not only the LFTs. Other point is about the staggered ingestion. So taking pills over hours or days for pain. These patients often present with therapeutic levels if we test the paracetamol, but we can have the established liver failure. That's why the nomogram should not be used for these cases. And in doubt, we should start the NAC, and we should consult a toxicologist, considering these situations are different than the acute overdoses. Let me. So we are at the end of this. We are at the end of this hour, and we can I wanted to thank you again, Dr. Lara, for sharing your expertise with us. Thank you so much to all our attendees for joining us today. You will receive this session is semi-accredited. You will receive the details, and also after this session, we will appreciate your feedback. You will receive a Zoom short survey after this session, and we look forward to seeing you the next month, December. We will have the ESM, and it's a holiday month, and we will resume our session, inshallah, later. You will receive invitation regarding this. And we look forward to seeing you, inshallah, at our next webinar. Have a wonderful day.
Thank you very much. Thank you, Dr. Samia.